let's go ahead and get started.
Okay.
So good morning, everyone, and thank you for joining us today. I'm Doppel Wilcox, the Community Coordinator at the New Jersey Healthcare Quality Institute. The Quality Institute is a nonprofit, multi-stakeholder advocate for the safety, quality, and affordability of healthcare for everyone. The Quality Institute oversees a statewide community health initiative called Conversation of Your Life, also known as COIL, which is a program of our Mayor's Wellness Campaign and generously supported in part by the Horizon Foundation for New Jersey. COIL aims to engage communities and residents in crucial advanced care planning conversations. We discuss topics like hospice and palliative care, various advanced directive documents, and how to communicate your wishes to your loved ones and healthcare providers. Our programming is being adapted to various cultures and languages. A public health crisis such as the one we are now facing with COVID-19 tests our strengths and highlights our weaknesses. The pandemic is prompting many people to consider the advanced care directives they may have been putting off. And we want to make sure you have all the information and resources you need to help make these decisions about the type of care you want. Like many of you, we are facing a transition to virtual programming, but rest assured, we are going to continue to provide resources and have these crucial conversations remotely through digital resources such as podcasts and webinars like this one today. First, a couple of housekeeping items. Please note that this webinar is being recorded and a copy will be posted to our website, www.njhcqi.org, later today. All phone lines will be muted for the duration of the program to limit background noise. You may ask questions at the end of the presentation by typing into the chat box or clicking on the Raise Hand button. The topic for today's presentation is advanced care planning, preparing for the unexpected during the COVID-19 crisis. Please be advised it is not the intent of this program or its speakers to provide clinical or legal advice. We are honored to have Katherine DeMarco, Clinical Supervisor of the Pain and Palliative Medicine Institute, Dr. Jose Contreras, Palliative Physician and Chair of the Pain and Palliative Medicine Institute, and Sandra Guzman, Palliative Care Coordinator, all of Hackensack Meridian Health's Hackensack University Medical Center, joining us for today's discussion. After a brief introduction from our panelists, we will have a moderated discussion and then afterwards open it up to the audience for a Q&A. Katherine, if you would like to get started and introduce yourself, the floor is yours.
Sure, thank you, and thank you for having us on today. So my name's Katie DeMarco. I have background in end-of-life care, palliative care. I've been fortunate to practice with this team for the past just over 10 years. I have a clinical doctorate in palliative care, and I feel very fortunate to work with patients and families on a daily basis to aid in their understanding of where their illness is and really how do we move forward together day by day to support their quality of life. So I enjoy many things within this field. It keeps us on our toes as we're able to help with that spiritual, emotional, and also physical aspect to people's needs.
Sandra.
Hi, I'm Sandra Guzman. Thank you very much for allowing me to be part of this panel. It's a privilege. I come from a hospice background prior to being able to join the Pain and Palliative here in Hackensack. I've been here for about 3 years, and my career has allowed me and given me such a gift to be able to be present at such vulnerable times with these families and patients. Thank you.
My name is Joe Contreras. I am by early training a family practitioner. I finished my residency in 2002, I believe, and then went on to do a fellowship in pain and palliative care at Memorial Sloan Kettering. I stayed there for approximately 3 years as an attending when I was offered a position at Hackensack University Medical Center. And after 2 or 3 years there, my passion for pushing palliative care along as a program and as an institute was continually driven to the point where I was able to get a leadership position to develop the program at Hackensack, and very grateful to have been able to assemble a great team that surrounds me and that provides great help to all of those in need, both in the outpatient, inpatient, and community setting.
Well, thank you all for taking time out of your busy schedules to join us today. And without any further ado, I'd like to begin our panel discussion. If those of you participating have a question for Katie, Dr. Contreras, or Sandra, please type it into the chat box throughout the duration of the presentation, and we will get to as many as we can before the end of this webinar. So the first question we have is, what is advanced care planning and why is it so important right now during the COVID-19 pandemic?
Sure. So this is a question that we could probably spend a day on, but it's such a rich and important question to start with. Advanced care planning is really an open conversation. That's the most fundamental and important concept for all of us to understand. Advanced care planning is the concept that we're open with ourselves, so an internal conversation, along with open to our loved ones. That could mean a spouse, it could mean a cousin, it could mean a core network of friends, but we talk about things that are important. We talk about what our lifestyle could look like or should look like even if we're ill, and even progress with illness in more of a serious or life-threatening manner. And this conversation usually evolves as we do. As we age into wellness or age into illness, this conversation should be modified in detail, as well as our own values or wishes may change. Our life is our context. So what I mean by that is, as you live with illness, whether it's cancer, heart failure, or anything else, as the illness changes, so does our experience of how we want to live. More formally, there could be documents that describe this conversation more readily. For example, Advanced Directive might sound familiar. Healthcare proxy might sound familiar. Legal documents that identify those wishes. And an advanced directive is more so identifying the living will portion, the words of I wish or I desire, and they identify which parts of medicine they would want or not want. Some classic concepts are end-of-life care concepts, such as do not attempt resuscitate or end-of-life care decisions. That's more so the living will, the narrative words in the document, where the healthcare proxy is identifying which person or people do you trust to be your voice and make your medical decisions if in fact you don't have the ability, meaning you're sedated medically or altered in your mind or thought process in some way. So those are some basic concepts about advanced care planning. Wanting to open it up to Sandra or Dr. Contreras if you have anything to add.
Okay. And would you say there's ever a bad time to start the conversation?
If I may jump in, I wouldn't say there's ever a bad time. There's moments of vulnerability that are difficult for families and patients to touch upon such a heavy, difficult conversation. However, there's always a way to introduce a hard conversation with families and patients.
Thank you.
I would say that, and she touched upon it initially, that probably the worst place to have these kinds of discussions is in the inpatient setting, which really drives the point home that we really should be having these kinds of conversations in a setting where we're not stressed, as Sandra had stated, when you're stressed, when a loved one is ill, when everybody's in the hospital and somebody's life is being threatened, it's very difficult to sit down and have a rational discussion. So just to add to what she shared, I would say that we should be having these discussions in the outpatient setting in the community with our families at times where we're planning for, you know, a potentially a good outcome. But if that outcome doesn't occur the way we would hope for, we've also discussed what we would want to do or what our wishes would be in a situation where the outcome wasn't looking so good.
Thank you. And so since you're all part of the palliative care division, I want to ask, what is hospice and palliative care, and what is the difference between the two of them?
So there is a very big difference between hospice and palliative care. We find ourselves talking about this all of the time because unfortunately palliative care tends to be looked at by the lay public and even really by some of our colleagues as a specialty that is end-of-life focused. And the key word there is palliative care is a specialty. As I mentioned earlier when I introduced myself, I am board certified in palliative care, went through a fellowship program, which is now the only way that you become specialized in palliative care is through a fellowship program as of 2013, which can be a year or 2 years of training after a primary board training such as family medicine or internal medicine. And so the point is we are specialists of medicine as a cardiologist would be a specialist of medicine or as a pulmonologist would be a specialist of medicine. And what I think makes it difficult for people to wrap their hands around the concept is that we are personhood based. So our specialty really in the most concise way of describing it is a specialty that focuses on the person in a holistic way, mind, body, and spirit, to preserve their integrity, to help them with loss when they're going with loss, to keep them as whole as possible. And we can do that when a person is born. There are pediatric specialists, and we can do that at the end of life or any time in the middle of life, beginning or end, that somebody is suffering, that somebody is fragmented, somebody is distressed by potentially a serious life-threatening illness. So that is fundamentally the key. Hospice is more a setting, and obviously it's a setting that 2 doctors have to certify that you would have 6 months or less to live. That's the way the government looks at it. It's a benefit that we all have. Almost every insurance and certainly the government pays for it. There are some similarities in that they are very much quality of life based, which we are as well. But it's more of an institution that one qualifies for with 6 months or less to live, that has some government benefits. But otherwise, the focus is definitely end-of-life care to the very end, with certain symptom management abilities like we would have in palliative care, and certainly psychosocial, spiritual, emotional benefit as well. It can be provided at home. It can be provided in the inpatient setting. And sometimes we even use hospice as respite for the family, since the caretaker burden could be so high in certain patients who really are dependent on their families or nursing assistants. So hospice is more of a setting. It is not a specialty of medicine, and it is completely end-of-life focused.
I think one of the benefits of people having access to palliative care is that upon a serious illness diagnosis, which could be anything from lung disease, cancer, ALS, the list could go on with examples, that we are able to join in with the patient who happens to be ill, with their family, and with their medical team to journey with them. And oftentimes palliative care gets to journey with patients and families to live for years, if not a decade or more. It just depends upon when do we all connect together in your chronic serious illness. So we're able to really get to know not only patients, but who are they as people? So that's the personhood concept that Dr. Contreras was speaking about. How do we uphold and respect them, even though they do happen to really be living with illness and having evolving illness at different stages?
Okay, and one misconception that people often have is that you have to be seriously ill to complete an advanced directive. And is it ever too soon? But before we get into that, I was hoping one of you might be able to explain what an advanced directive is and how you can complete your own.
So an advanced directive is a legal document that identifies the person that you have had or open these difficult discussions with, and identify that person as making medical decisions on your behalf when and if the time comes that you're not able to. So you can identify a primary, a secondary, and a third person to assist with that medical decision making.
Got it.
I often recommend that anyone who is able to speak about their own wishes or who they trust about medical decisions, say 18 and up, is really the time frame where we should start talking about these concepts. Even thinking about 18-year-olds, they are driving on the highway. They could have car accidents. We often have access to smartphones, and the EMS team, they actually look on smartphones often to identify if there's an emergency or even a healthcare proxy identified in the medical emergency application on their phone. So oftentimes we may hear that families hesitate about talking about these concepts with someone so young, and we just want to normalize and open it up that these conversations are important, and they evolve as we age. They evolve as our illness evolves. You know, a lot of us are all healthy, and likely we all should have our own healthcare proxies identified and some baseline information about values identified.
Interesting, Katie, that you should mention, being even a late teen or adolescent, when you can get your license, you're often asked if you'd want to be an organ donor. And, so at the same time, if you're thinking about that, the possibility of that tragedy that we don't have any control over, you might also want to have a conversation with a loved one that if that did occur, what your values and wishes would be.
And like you mentioned, you can be 18, have your license, and sometimes 18-year-olds, that's like at the end of life care planning is the last thing on their mind. So I wanted to ask you guys, what are some of the biggest barriers to having these end of life or advanced care planning conversations that you've come across in your experience?
One that comes to mind is culture. In some cultures, it's still taboo or not wanting to touch upon until that time arrives. So
how do you best address the topic with patients of various cultures and religious and spiritual backgrounds, would you say?
So when I have the privilege to be in a space with families and having to introduce these hard conversations, I ask for permission. May we start a difficult conversation? And most of the time, they are very open to exploring that. It seems like from my experience that they are wanting to talk about those hard conversations, but just haven't had the safe space to do so.
And building upon that, but in a different environmental setting, in this COVID season, unless you're most of us are home rather in this COVID season. And so we have a lot of time where we're either doing this or virtual FaceTime situations, or even speaking with our families and hanging out with our families at home. It could be an opportunity just casually now to bring up, what I call what if or I wish situations. And you could say to your spouse, your friend, whoever you value, and having this conversation to say, I wish I could talk about, a what if situation. Can I do that with you? And that's really the start of the conversation, an icebreaker to start talking about, what I would not want, or what did a loved one have that you didn't value when you think about it in retrospect. Sharing stories of difficulty kind of start to ground you in what might be okay or not okay. But bring it to the dinner table, bring it to the home setting, have that family friend conversation.
I would say, just based on what my colleagues have just mentioned and backing up a little bit in terms of culture, and really in terms of humanity, death has always been taboo. The subject of death is taboo, and to some extent, we really don't begin to wrap our hands around it until we're older and starting to become frail, and knowing that maybe the time is limited, but we're always and have always been, as human beings, seeking the fountain of youth. And I thought about that when Sandra was speaking. But I would say fundamentally one of the biggest barriers, and at least in this country, is the care provider. And when we talk about palliative care and hospice and advanced care planning, it is not just the realm of palliative care or even hospice to discuss or have advanced care planning discussions. It's really the realm of all care providers across the board: physicians, APNs, physicians assistants, and I think that they are the ones in large. Probably majority that just have a difficult time even beginning to have that discussion with their patients. And earlier on, we spoke about the importance of doing it in a comfortable setting. But there's this fear that somehow if you begin to discuss these sorts of topics, that people wonder, well, why is my doctor talking about this? What is he trying to send me a second message about maybe my course is not going to go well, or whatever the case may be. We've tried to get around, setting these important discussions up by, for example, asking inpatients if they've had advanced care planning discussions, or if they have an advanced directive. They'll get questioned that across the board, but it doesn't really go anywhere. We really need to get much better about being comfortable having those discussions as just a part of a routine visit. Maybe once a year you go over it again with your patient, or once every couple of years. Certainly when somebody's healthy, it's not so important, but we also discussed the lack of control that we have at the end of the day. So I would argue that we need to get our care providers more comfortable with having this discussion, and setting up the platform to be able to do it in a non-stressful, a low emotional, higher rational moment.
Okay, and another barrier that I often hear, like, as you say, we want to have these conversations, but I hear people asking questions like, don't living wills or advanced directives require a lawyer and cost money? Is this true, or are there any other forms that don't require all of this?
Yeah, good question, good thoughts. And that is a lingering concern, is what is the financial burden potentially to these legal documents? And being that we all live in New Jersey, we're a very litigious state. And so we often find ourselves thinking about, how do lawyers or the state impact the process of how we go about this? The good news is that completing an advance directive is absolutely free. There are so many state-based and national resources that make it so. Giving an example of Hackensack University Medical Center, we do have advance directives where you can identify your healthcare proxies as well as some personal information. All it takes is the willingness for the person to complete it and 2 witnesses. You do not even need to pay a notary public to stamp it. And some other organizations, such as Robert Wood Johnson Foundation, working with the 5 Wishes, is another example, exterior to Hackensack. A lot of religions and community resources, such as the Catholic Church that you might go to, or your local community center, or any other cultural or religious organization, they too often have their own form for an advance directive, and that might very much align with you and your values. And another starting point that is free. Lawyers do have a place and space to offer. They are a resource. It does cost money, but it is not required. So it's a personal choice to work with a lawyer who has knowledge to this type of legal form.
Understood. Okay. And especially in a time like right now, what happens if you don't have any documents prepared which describe your final wishes and you're, say, admitted to the ICU and you're unable to speak for yourself, you don't have a proxy selected? What's the process that goes on in the hospitals?
We start to explore a little bit with next of kin, relatives, to see and learn more about the patient and who is their legal next of kin, and able to make medical decisions on their behalf. So it does take us a little bit of investigation of getting to know the person and their values.
Mm-hmm. It is important that we, not knowing the person who is, say, in the ICU and intubated, that we learn about their family structure and family tree more. It's very important that we don't assume that the person that's repetitively calling is necessarily the medical decision maker. It may be a very close loved one, but the state does give a specific hierarchy of who would be that next of kin. So with that state guidance, the healthcare professionals can start engaging with that person and additional people if that next of kin desires it. The most clear example is if I was in the ICU, my legal husband would be my next of kin to make my decisions. But of course, not everyone is married, and there's further structural and legal guidance from the state, as everyone has a different family structure. It does sometimes feel a little bit more complicated when we don't have clarity yet.
And it's not uncommon that, you know, even once identifying the next of kin, it may not be uncommon. There are certain tragedies that occur, you know, at any time in one's life, and maybe those discussions just simply haven't been had. And that can be a particular challenge to the loved one, to that identified next of kin who just didn't anticipate that this would happen. And that's part of the problem, which is why we argue, really, as soon as you can encourage people to have those discussions, the loved one would then have a better sense than if they hadn't had those discussions at all. Obviously, there's a certain intimacy between the next of kin and their loved one, and they probably could guesstimate some sense of what their loved one would want. But sometimes it might just boil down to simply that. It's just knowing that person and trying to empathize with them and trying to come up with how they might want to be treated in a certain situation. you may even develop that kind of intimacy with a good friend and just have a very good sense of what their philosophy is. You may have had those discussions one late night, etc. So sometimes it can be a bit of a guessing game.
Got it. And that kind of ties into the next question that I had. It was many people have tried to encourage their loved ones to complete an advance directive, but they often find that their loved ones just don't want to hear it or talk about death at all. They just want to kind of ignore it and act like it's not going to happen to them, even though it is inevitable that we all will face this problem at one time or another. Is there any different approaches that you guys have or any conversation starters that patients and family members have responded to in a positive way?
One strategy that I've used in that situation is if people don't want to talk about what they do want, I ask them to kind of create in their mind a line in the sand of what would be absolutely unacceptable. And in some framework, define that so we don't by accident or on purpose step over that line. That too can be a conversation, of course, but that seems to just draw on kind of the yin or the yang approach of just taking a different angle. And I have received some concrete concepts that patients and families were able to give us, which was helpful.
Okay, and so I just want to say thank you all for that helpful information. And before I open it up to the audience questions, just a quick reminder that this webinar will be available on the COIL webpage so that you can review the information you may have missed and can share it with your family members and friends. We have other resources available for you too, such as our advanced care planning, preparing for the unexpected one-pager, where we have compiled trusted resources, all accessible from home, to help you and your loved ones start thinking about your wishes and strategies for how you can comfortably approach these important conversations with one another and your healthcare providers. We encourage you to take a look at this document and share it with your family and friends. And stay tuned. COIL will continue to push out resources such as one-pagers and webinars for residents and healthcare providers. We do have a question from Lorraine. It says, is 5 wishes a good document to use?
Good depends upon your processing and the approach that you like to use. I find that 5 wishes is helpful for the adult population that likes to be prompted with options, but also have an area to write down some personalized thoughts. The 5 wishes brings you through different concepts to think about within yourself, with your healthcare proxy, and maybe even with your physician or care team. It's more detailed than other generalized advanced directives. Oftentimes, if people feel overwhelmed by completing the 5 wishes, I do recommend people to review it, as it will prompt thought and the discussion. So that's probably where 5 wishes is excellent for the adult in general. But you will know when you see it if you value it enough in detail to complete. So that would be my thought. Sandra, do you have thoughts about the 5 wishes?
No, I would just align with what you said. It is more detailed, and it does have good prompts in discussing signs and symptoms and end of life type of symptoms that you'll see, or changes that will progress.
And we had a question from James Curcio. He was asking if we could please explain the PULSE role, timing, and process.
Sure. So PULSE in the state of New Jersey is practitioner orders for life-sustaining treatment. And it is often thought to consider completing this form when you have a life-threatening illness, and there may be more so a couple years of life to live or less. In addition, I would suggest that any person who is elder and wants to make their wishes not known, but rather ordered, that's another subset of people who could complete the post. Going beyond these two general populations, however, a post form can be completed even for a little baby in the neonatal ICU if in fact their parents and their care teams are identifying that there's a life-threatening illness and they want actionable orders to be completed. So post is not driven by age. Usually it's driven by prognosis. A post form has several different sections, and this is where we're able to personalize the conversation and the document. The person and either the physician, physician assistant, or advanced practice nurse would have a discussion and understanding of diagnosis, illness trajectory, meaning what is the anticipated path of illness, the prognosis, as I already mentioned, along with personal values, and putting it together on our state green form. This is a state form that is transferable and universally acknowledged, and everyone from EMS to home care to hospice to hospitals everywhere in the state of New Jersey need to honor it when completed appropriately and completely. There are a lot of subset of rules, and thankfully those rules and guidance is on the back of the green form. We ask people to treat it like their driver's license. Where the patient goes, the post goes. And it's very important that that happens, so when the patient enters a different care site or environment, the care team, the receivers, can look at that form and honor what the wishes are, or start a conversation on why they recommend modifications to the care plan, modifications to the post form. I think I'll pause here because I anticipate Dr. Contreras and Sandra might have some concepts that they would want to add in about the post.
I have a couple of additional thoughts about it. One of them is just the ideal time. Some of you out there that are in the audience have probably heard of the surprise question, which could be a helpful clinical prognostic tool. And basically the surprise question is, would you be surprised if your patient did not live up to 1 year, or that the likelihood of their passing is approximately 1 year? And in terms of the timing of post, the recommendation is roughly 1 or 2 years left in one's lifetime, whether it be a pediatric patient, as Katie mentioned, or an adult, in terms of the appropriateness. And then again, consistent what we've talked about earlier, doing it in a setting, a less stressful setting like your home or at your doctor's office. So that there is plenty of time to go over the details and nuances. The other thing that I wanted to mention about Pulse, which is I think a very cool thing, is that because we do live in a system that is to some extent fragmented and broken, especially in terms of end-of-life care, one of the, I think, impetus for the development of this form is to get on paper some good idea of what the values and wishes are that the patient might have. And in fact, at the top of the form, there is a blank where you can kind of a blank area where you can handwrite as a patient. And the key is the patient is still able to do this, so you don't get into a situation where the patient is unable. Just mention very briefly what's important to them, what would be important to them at the end of life, and what are their most important values and wishes. And then the other cool thing is we're not the only state that has a form like this. And I thought I would mention it because of the importance of having kind of a cohesive way of addressing these kinds of things that at the end of the day are very important to people when you ask them. If you don't ask them, then you're not going to know. But these are the kinds of things that are very important to us and very intimate in a certain way. I don't know the number, Katie might, but I'm sure it's over 40 states, maybe 45 states that now have a form very similar, whether they call it medical orders or physician orders, MOLST or POLST, so that someday it will be a universal form within our country. And not only would it go from one setting to the next, as Katie mentioned, but also one state to the next, so that there wouldn't be confusion about what that person wanted. And I think that's from a conceptual point of view, a very cool thing.
Thank you for that. And we have another question that was actually posed while you were explaining the difference between hospice and palliative care. How often does the palliative team meet with patients at home, and who goes to care for them? Home health care aid for activities of daily living, and does a nurse visit on a regular basis?
So if you oh, I'm sorry.
That's okay. I just wanted to clarify that they're asking specifically about palliative home care.
Yes.
Okay, thank you. Go ahead, Dr. Contreras.
So within our network, Hackensack Meridian Health, we do have community palliative care programs, mainly focused in Central and South, where it's usually a nurse practitioner. It could be a physician assistant. It could be a nurse, but it's usually a nurse practitioner who goes to a patient's home really on demand, depending on how symptomatic they are and what their patient caseload volume is. It is the future of palliative care for sure, because of our wanting to move the care of patients upstream and outside of the hospital. Many of our palliative care patients have difficulty getting into any care setting. We've had an opportunity to dabble during this COVID pandemic in doing telehealth. So we're meeting people virtually at their homes, which is the next best thing than being there personally. And it has actually gone very well. And I see it as a precursor to us as palliative care specialists getting into the home. The problem with home-based palliative care is it is expensive. You can't see that many people in one day, obviously, because of the geography. So you want to have an area, you want to be able to provide this kind of care if you're going to do it personally in areas that are fairly densely populated, so you can maximize the amount of patients that you see. But it can be of great benefit to those that just physically can't come out to visit you, whether in the, well, ideally in the outpatient setting. It's definitely one of the goals that we have to establish a community-based program. And I think this crisis has set kind of the stage to move in that direction with our telehealth visits.
One of the challenges with home palliative care is that there are program variations throughout our state and throughout our nation. What I mean by that is there are home health agencies in our state that offer palliative experience or palliative programs complementing the home traditional visiting nurse system that they already have. That might be what the viewer is referencing regarding the home health aides. If there's in fact a specialty palliative care program that is a separate program than a traditional visiting nurse service. So for example, when Dr. Contreras goes into the home, if Sandra went into the home, if I went into the home, we would be doing home palliative care, but not working with a home visiting nurse agency. A lot of specialty palliative home-based programs do not necessarily offer home health aides because the visiting nurse service does. And so it can feel confusing to the public and confusing to even developing programs about how do you complement each other. And so these are some of the growing pains that the field is going through. We know that palliative care is needed in the home, but we're all creating programs that are meant to be complementary of what already exists. Unfortunately, patients and the families are also navigating those similarities or discrepancies, and that can be really difficult. So we would recommend, if you feel you would benefit from home palliative care, that you reach out to your, say, local hospital who has a palliative care team and start exploring, what is in my area? How can I get some help?
I think that's an excellent point, because it can be confusing, and maybe the person who's asking is thinking about primary palliative care services, because that word can be used loosely. And I think that is the key: primary palliative care and not specialty. Specialty is exactly what we have been talking today, and especially when we define what we do as palliative care specialists. And it's a much more sort of detailed and comprehensive approach than you would be getting if you were getting basic primary palliative care that really any provider could provide.
Okay, and we have another. What happens if I haven't filled out my advance directive yet and I don't have any remaining family, friends, or loved ones, and no longer am able to speak for myself? Who becomes my decision maker, and what are the protocols?
Mm-hmm.
Great question. Sandra, maybe you want to take a stab.
To be honest, that we would need to look into having the state appointed for assistance with making medical decisions if there's no family, there's no friends, nobody identified as being able to assist with those difficult decisions.
When we work with the state regarding those concepts, we do have the benefit of the state giving us guidance that even if there's an open and willing neighbor, because there are no other connections, social connections to this person, and if the neighbor, for example, has knowledge to the person as they are or their values, we have been able to use even distant but social connections before we seek guardianship. If you're in a situation where you do not have, those people in your life as you identified, one of the thought processes could be is having that advance directive given to your local hospital, having it uploaded to your medical chart, as well as making sure that it's available to, say, your physician team when you see your primary care doctor or others. It also could be just a way to think about how are you going to share the information, even though you don't necessarily have an emergency right now, but you're kind of pre-planning transparency if you don't have an obvious person to work with. The living will part of the advance directive, that narrative piece where it's literally words and paragraphs of identifying if I was terminal, I would want, or if I was in a coma, I do not want. Those things are very rich and helpful to the nurses and doctors. And if we have those documents, we can very much honor and put together a plan very, very much more readily and smooth, rather than explicitly and solely working with the state.
And this one goes back to hospice and palliative care. Are the benefits covered on hospice better than palliative care at home? That's weirdly phrased, but I don't know if you guys.
So the benefit is completely different. Again, there's a hospice benefit that the CMS provides for most Americans and other insurances as well. It's a limited amount of money that the hospice programs will get depending on the type of visit they're making, whether it be in the inpatient or the outpatient setting. It's set, in a specific sort of number that it's sort of a it's an all inclusive payment that they would get, no matter what medication they write for. Obviously, the types of treatments that one gets is very limited. You have to give up sort of what we would call, life-sustaining or the types of treatments that really, at a point when somebody is reaching the end of life, are no longer useful, like getting some kind of a important or complicated surgery, or continuing to receive chemotherapy, or even radiation therapy. Anything that would be designed to more sustain life would not be covered by hospice. It would be just the services of helping out from a symptom management perspective and from a quality of life perspective with the visiting nurse who could be by the patient's bedside maybe an hour and a half a day, maybe 4 or 5 days a week. Whereas specialty palliative care, as I mentioned, again, the word being specialty, as in a nephrologist or a pulmonologist, we charge for each visit depending on the complexity of the visit. If it's a fairly quick turnaround visit, then there's a certain charge. If it's more comprehensive, then there's another charge. If there's an acute problem that requires some imaging, we would charge based on the complexity of that visit. So it just varies. It's akin to going to see your specialist on any level. Obviously, when you're receiving specialist palliative care, as you're also concurrently receiving care from your cardiologist and your internist, you are able to pursue, aggressive measures such as chemotherapy. You are able to have that surgery if you need it, or go towards any sort of curative treatment protocol that you feel that you need. Whereas hospice clearly will limit that those sort of treatment protocols to basically protocols that are focused on quality of life and symptom management.
Thank you for that. And in lieu of the time, I'll get to one last question. If I have multiple advanced directives and haven't had a chance to destroy my old ones or declare them as revoked before I lose my ability to speak for myself, which form takes precedence over the others?
It would be the most recently completed.
Most recently, okay. Okay, and that seems to be all the questions we have for now. I do want to thank all of you guys for taking the time to come sit down and speak with us today. And just to go over it, everything again, this is recorded and this will be uploaded to njhcqi.org later today for anyone who missed any parts of the conversation. And yeah, I just want to say thank you again for you guys taking time out of your busy schedules. I know you guys are out there on the front lines every day, so thank you very much, and it's greatly appreciated.
Well, thank you, and thank you for having us.
Of course.
It's a pleasure. Thank you.
Thank you, and enjoy the rest of your days.
You too.